patient is in supine with the arms positioned alongside the body. The hips and knees are bent approximately to 90 degrees, and the feet are resting on a chair. The pelvis should be in a neutral position. The therapist stands behind the patient. First, it is important to position the thorax into a neutral alignment. To do this, the therapist places their hands on the lower angle of the ribs. During normal breathing, with expiration, the therapist guides the rib cage into an expiratory position. The sternum, as well as the entire rib cage, moves caudally during expiration. During inspiration, the sternum and the clavicles do not move cranially. Rather, the lower section of the rib cage widens. The therapist's hands are positioned in the angle and do not contact the abdominal wall. The pressure is applied in a caudal, dorsal, and lateral direction. The patient should find this maneuver pleasant and should be able to relax. The patient is instructed to attempt to maintain the rib cage in an expiratory position. The therapist gradually decreases the amount of manual guidance until complete elimination. The infrasternal angle should reach 90 degrees. If the angle is smaller, the therapist's hands guide the lower ribs in a dorsal, caudal, and lateral direction. If the angle is larger, the therapist's hands guide the ribs medially, dorsally, and caudally. This procedure is repeated several times. The patient should maintain the initial position of the shoulders, head, and lower extremities. The head and cervical spine should not move into extension, nor should the shoulders move into protraction. The therapist must also observe the abdominal wall. The contour of the abdomen should be fluid. There should be no visible concavities in the groin areas, which would indicate hyperactivity of the rectus abdominis. After several repetitions, we can progress to facilitation of the abdominal wall, especially in the lower parts of the abdomen. The patient is asked to inhale, exhale, and during exhalation, push their abdomen against the therapist's fingers that are placed in the lower part of the abdomen. Another option can be facilitation of the abdominal wall in its dorsal lateral sections. Patients should be able to expansively breathe into this area without strain. The idea is to teach the patient to control intra-abdominal pressure. During inspiration and expiration, the entire abdominal wall should remain active, not just the anterior portion. Active movement of the extremities can be implemented once the patient can achieve neutral position of the trunk and can use intra-abdominal pressure to correctly position the pelvis and spine. The patient is asked to lift both lower extremities from the chair. If they are unable to lift both legs simultaneously, they can unweight just one at a time. In this case, the therapist needs to make sure that the other extremity is not actively pushing into the chair. The therapist can check for this pressure under the patient's calf. When done properly, the leg should remain relaxed. The therapist observes coordinated activation of the abdominal wall. In an ideal scenario, the belly button moves caudally and there is no concavity above the groins. A concavity would indicate increased amounts of rectus abdominis activity. Head and shoulders should remain in their initial alignment. For better awareness of the dorsolateral parts of the trunk, we recommend our patients to place, for example, foam balls into this area. It is then easier for the patient to breathe into these areas. When the trunk is correctly stabilized, the patient can move their lower extremities into flexion and extension. All segments, head, trunk, pelvis, and spine, maintain their neutral position. The movement occurs selectively in the hip joint. Patient breathes normally and uses their fingers placed above the groins and the lower dorsolateral part of the abdominal wall to feel and control intra-abdominal pressure distribution. More difficult progression is shifting the trunk to the left or right side without changing the positions of the initial segments. In this position, the patient can practice alternating movement of the lower extremities. The patient attains the described starting position and moves in the same direction, always moving their diagonal extremities. If the lower extremities fall into abduction, we can approximate the hip joints. The patient is instructed to breathe into the lower abdomen. The therapist, using their trunk, pushes into the left lower extremity against the pelvis along the long axis of the femur and asks the patient to slightly push their right lower extremity into abduction and external rotation against the therapist's contact hand. Another option can be approximation of the left lower extremity into the hip joint. On the right side, the patient practices isolated movement of the hip. The 3-month-old position can also be used for facilitation of the deep neck flexors. The therapist stands behind the patient's head. Their fingers are placed on the spinal processes of the cervical vertebra and depress in a ventral direction, while the patient creates counter pressure. With correct activation, we should not observe hyperactivity of the sternocleidomastoid and instead observe a fluid neck contour. Then, the patient elevates their upper extremities until the shoulder blades are in full contact with the mat. The lower extremities are resting on a chair. The patient is instructed to smoothly lift their head and look at their knees to practice head flexion. If the patient finds this movement difficult, they can practice head lifting with assistance at first. The therapist stabilizes the patient's sternum and guides the head into flexion. Gradually, as the patient improves, the assistance is decreased. The activity of stabilizing muscles can be facilitated by the therapist resisting against an active movement of the upper extremities. For example, the therapist resists active movement into arm abduction, external rotation, and supination. This will reflectively activate the trunk stabilizers. The therapist applies the force to the lower extremities, pushing them into internal rotation and adduction. The patient then creates a counter pressure. The amount of pressure must be adequate to the muscle strength that the patient requires to stabilize the trunk. If the pressure is too strong, the patient automatically uses the superficial, powerful muscles, and the movement occurs with a compensatory, non-ideal stabilization model. The patient attains the basic initial position in supine, bends the legs with the feet resting on the mat. A large ball is placed on the abdomen so that it also contacts the thighs. The upper extremities are positioned on the ball in flexion, abduction, and external rotation, in a bear hug position. The therapist checks the position of the shoulder blades, head, and neck. The patient positions the rib cage into an expiratory position and activates the abdomen, as in the previous exercise. The right hand pushes the ball against the left thigh as the patient was trying to deform the ball. The ball stays in place and the lower extremity stays in contact with the ball and the mat. The therapist checks for coordinated involvement of the abdominal wall. More difficult progression is administered in the same manner as the previous exercises. The lower extremities are positioned freely above the mat in triple flexion. In the starting position, the patient holds the large ball between their hands and knees. The patient shifts their weight towards one side and tilts towards that side without changing the initial alignment of the individual segments. During the movement, the trunk maintains its position and does not bend. The axes between the shoulders and the hips stays parallel. The head is in line with the spine and moves at the same speed as the trunk. Now we are going to present several other options. In the initial position, the patient tosses the ball between their upper and lower extremities. Increased extremity flexion increases the difficulty of the exercise. In the initial position, the patient turns the ball using alternated movements of the contralateral extremities. Rhythmic stabilization can be another option. The therapist tries to push the ball in different directions, the direction, speed, and force of which can be varied. The patient holds a kettlebell and moves it craniocaudally, side to side, or diagonally. The patient places a resistance band around the lower and upper extremities. The band is placed across the shin bones, crossed behind the thighs, crossed in front of the thighs, and around the lateral side of the hand towards the thumb. The hand should be softly open. There are several examples of exercises with a similar setup. The patient maintains the starting position against the resistance of the band, breathes into the dorsolateral parts of the trunk, and maintains the chest in an expiratory position. The patient must pay attention to the spine straightening, the position of the pelvis, and the contact with the mat. To make it easier for the patient to maintain neutral position of the trunk, the patient moves the upper extremities into external rotation during expiration, while simultaneously moving the lower extremities into slight abduction and external rotation against the pull of the exercise band. With inspiration, all extremities move towards the midline. This exercise can also be performed in the opposite respiration synkinesis. From the initial position, the patient moves the upper extremity diagonally into abduction and flexion. In the starting position, the patient leans against the resistance of the band, and the entire body tilts towards one side, loading that side more than the contralateral side. The head should not bend against the resistance or move ahead of the trunk. It should remain neutral. The shoulder and pelvic girdles and the head all move at the same speed. During exercise in 3-month-old position, in supine, the upper and lower thorax should stay connected and none of the segments should deviate from a neutral position. Weight, resistance band, or the therapist's resistance must always be adequate to the strength and coordination of the stabilizing muscles. The patient is then prone with the neck in a neutral position. Ideally, if lying on a table, the nose should be in an opening on the table, or the patient's forehead could be slightly elevated with a pad. The upper extremities are resting freely alongside the body, and the lower extremities are freely resting on the table, extended, and the toes positioned just off the edge of the bed. The therapist instructs the patient as follows. First, move your arms up onto the table so that the elbows are in contact with the table, they are slightly bent, and the wrists are in line with the shoulders. Second, press the elbows into the table medially and caudally towards the belly button. The shoulder blades will begin to move caudally and slightly into abduction, therefore into a neutral position. During support, the cervical-thoracic junction automatically straightens. the muscles are working in a distal direction, meaning towards the support on the medial epicondyles. The cervical spine automatically achieves a centrated position, and the activity between the deep neck flexors and neck extensors becomes balanced. The therapist palpates the lumbar spinal prostheses and asks the patient to try to push the therapist's fingers towards the ceiling, thereby decreasing the lumbar lordosis and the anterior pelvic tilt. To achieve this, the abdominal muscles need to be activated and the intra-abdominal pressure increased. Only minimal activity of the gluteals and lower extremity muscles should be observed. Another facilitation that can help the patient obtain correct pelvic alignment involves palpation of the lower abdominal quadrant, in the groin area, about 1/3 medially from the ASIS. The patient is asked to push the abdominal wall against the therapist's fingers. The patient performs this maneuver by increasing their intra-abdominal pressure. If the patient is unable to change the position of the shoulder blades, we can initially work separately on one and then the other extremity using different techniques. For example, we can approximate the humerus with the scapula, we can also use distraction technique, in which the therapist lightly pulls on the medial condyle of the humerus along the axis of the humerus in a distal direction. Like approximation, this facilitates muscle activity. It is important to use only light force. In another scenario, the therapist grasps the lower angle of the shoulder blades and pushes the shoulder blades in a cranio-medial direction. The patient works against the therapist's resistance to facilitate the lower scapular stabilizers. The therapist can also guide the shoulder girdles away from a centrated position, for example by changing humeral rotation. The patient will resist this force and attempt to actively maintain proper positioning of the shoulder complex. It is important that the therapist uses light pressure sufficient to create a reaction, but not so forceful that the patient is unable to correct the position. If the patient can maintain the initial position, the position of the trunk, shoulder blades, spine, and the pelvis, we can add the following instructions. Lightly lift the head from the table as if I wanted to slip a sheet of paper under your forehead. None of the segments can deviate from the initial position. The patient lifts the head from the table without mid or upper cervical extension. The small range of extension should be distributed throughout the upper thoracic and lower cervical segments. Lift the head from the table and turn your head slightly left and right, about 30 degrees. The head should not laterally bend, flex, or extend. Muscle activity is being observed. During movement, the muscle contour of the neck should be smooth and round, without prominence of individual muscles and without upper cervical extension. The patient should breathe freely throughout the movement. In this position, the segmental mobility of the lower cervical and upper thoracic spine can be practiced. The patient is instructed to lift the head so that they can feel movement in a given segment. At the same time, the therapist is palpating the cervical thoracic segment and moves craniocaudally to provide the patient with some feedback. The patient should be able to breathe normally in this position and should breathe into the dorsolateral aspects of the abdomen equally as much as they breathe into the ventral portion. The patient regulates the intra-abdominal pressure without excessive activity of the superficial muscles, trunk extensors, trapezius, hamstrings, etc. To increase awareness of support, axial resistance to the head can also be used. The therapist applies slight pressure to the head in the axis of the spine, and the patient works against the therapist's resistance. Similarly, exercises can be performed in low kneeling with forearm support. The patient is in a quadruped position with the toes off the table. The patient shifts their body back and sits on the heels while the upper extremities are supported on the table with the elbow on the table and the forearm pointing slightly medially. The head is in line with the spine. The patient is instructed to push the elbows into the table simultaneously in a medial and caudal direction towards the belly button, causing the shoulder blades to move into a caudal and slightly adducted direction, bringing them into a neutral alignment. The therapist applies pressure in an axial direction. The cervicothoracic junction automatically straightens, and the muscles work in a distal direction, meaning towards the support. The therapist applies slight pressure into the hand in the direction of the elbow and the shoulder girdle. This pressure applied at the periphery facilitates uprighting of the spine and uprighting of the clavicular joints. The head maintains an elongated position. If the spine strays into kyphosis, the patient is asked to move their entire trunk slightly forward. The pelvis is brought into a higher position where lumbar kyphosis can be more easily controlled. The therapist then applies an adequate axial pressure. The patient should be aware of the points of support and spinal straightening. Starting position. The head, spine, and pelvis are in a neutral position. The patient maintains this position and brings their right lower extremity to approximately 45 degrees of hip abduction and 90 degrees of knee flexion. Given the change in base of support, the ipsilateral upper extremity becomes unsupported and can perform active movements from this position. In this position, the patient uses diagonally located points of support. On one side, it is the medial humeral condyle, and on the other side, it is the medial femoral condyle. The patient's free upper extremity can be used for active movements utilizing either weights, the therapist's resistance, or a resistance band. Transitional movements can also be utilized in therapy. This video involves the transition from the 3-month-old model to the diagonal support position that an infant should be able to attain by 4.5 months of age. The emphasis is placed on maintaining intra-abdominal pressure and correct support points both in the lower and upper extremities. Starting position. The patient is in sidelying. The bottom shoulder is in 90 degrees of flexion, with the elbow also flexed 90 degrees. The shoulder blades need to be guided into a neutral position with the medial border virtually parallel to the spine. The inferior angles will be slightly abducted relative to the superior angles. The bottom, supporting lower extremity is semi-flexed in both the hip and the knee. This angle can vary based on the kyphosis or lordosis of the lumbar spine and morphology. The top upper extremity, or phasic arm, is positioned on the trunk, and the top lower extremity, or phasic leg, is positioned on top of the bottom lower extremity. The head is supported on a mat so that the spine is straight. In the frontal plane, the body is positioned so that the axes of the shoulder and pelvic girdles are parallel. The top shoulder will be directly above the bottom shoulder, and the top hip will be directly above the bottom hip. The kypholordotic curvatures of the spine should not be excessive. In this position, we can work on connecting the upper and lower trunk. The bottom upper extremity is supporting on the lateral aspect of the arm on the table. The elbow remains in semiflexion. To perform the exercise, the top upper extremity will move into flexion abduction, and external rotation against the resistance from the band. The therapist can also resist the upper extremity movement as well. Practicing an isolated movement in the hip joint between the pelvis and the femur and sidelying. During this exercise, the hip external rotators and abductors are facilitated while the pelvis maintains its position. It is important that good control of the intra-abdominal pressure is maintained throughout the exercise. The initial position is the same as during the previous exercise, only the bottom lower extremity is in 90 degrees of hip and knee flexion, and the top lower extremity is initially positioned on the bottom lower extremity. Then, the movement of the pelvis is observed, which moves through the space just like the trunk. There is no change in abduction or adduction angles. The therapist facilitates the outside of the knee using hand contact or foam ball, etc., and the patient attempts to push into the table with the same intensity throughout the entire duration of the movement. The patient tries to smoothly roll the pelvis back and forth. The pelvis, trunk, and head move as one unit at the same speed. We should not see disconnection between the upper and lower trunk. The therapist demonstrates different options for hand placement during the exercise. Similarly, the patient can practice isolated movement of the upper extremity with the trunk stabilized. The therapist grasps the bottom upper extremity at the heel of the hand. The therapist then applies pressure in the direction of the scapula to facilitate approximation. The patient uprights on the supported arm and rolls the trunk forwards. The head and trunk are moving as one unit. Ideally, the elbow flexion angle does not change throughout the exercise. Initial position. The patient will start in quadruped with the wrists and knees directly beneath the shoulders and the hips. The hips and shoulders will be flexed approximately 90 degrees and in slight abduction and external rotation. The spine should be in a neutral position with the head in line with the spine. The patient will be looking between their hands. The patient distributes support equally over the entire surface of the palm and fingers. The patient is then asked to move their hands approximately 30 centimeters forwards. The degree of abduction and external rotation does not change. The patient moves their trunk forwards so that the trunk and the thighs are in one line. In this position, the hips will be in a neutral position with no hip flexion. The movement occurs only in the hips and the shoulders. The pelvis maintains a neutral position the entire time. The shoulder blades are in a neutral position and the head remains in line with the spine. While in quadruped, the patient slightly shifts their trunk forwards and backwards. During the exercise, the patient should keep the pelvis in a neutral position. The patient should not allow the shoulder blades to adduct or the spine to sag in a ventral direction into extension. During the exercise, the therapist should pay attention to the thoracic kyphosis and cervical lordosis as well. There should not be any significant change in these curves during the exercise. In patients with anterior pelvic tilt, This transition movement from sitting on the heels to 6-month-old position is very beneficial. The pattern is not present in ontogenesis. However, it can be used to train trunk stabilization with activation of all extremities in a closed kinematic chain. It is also a very powerful exercise to train pelvic control. In supine, the patient will maximally flex her hips with partial abduction and external rotation. The knees will be flexed enough to get the shins perfectly vertical. Based on their hip mobility, the patient either grasps her feet, ankles, or shin bones. The head rests on the table with a centrated cervical spine, the rib cage is in an expiratory position, and the shoulder blades are in a neutral position. The pelvis should not be in a posterior tilt. The center of mass will shift cranially, and the patient will load on the thoracolumbar region. The base of support is formed by the head, shoulder blades, and the thoracolumbar junction. The therapist can assist by facilitating the lower abdominal region and correcting the position of the head, thorax, and shoulders. Patient instruction: grasp your feet, level your shoulders, and slowly breathe against the pelvic floor. The patient should focus on the connection between the thorax and the pelvis. The patient moves the upper or lower extremities while maintaining proper trunk stabilization. In this position, the activity of the deep neck flexors can be trained. The therapist stands at the patient's feet facing the patient. Using lower extremity approximation, the therapist presses the thoracolumbar junction into the table. To increase the difficulty of the exercise, the patient can perform active upper extremity movements. For more advanced patients, weight can be added. In the 6-month-old position, similar exercise modifications can be practiced as in the 3-month-old position. This includes ball rolling, ball throw, active extremity movement with or without weight. The difference is in the alignment of the pelvis and the lumbar spine. While in the 3-month-old position, with an entire straight spine, the pelvis and the lumbar spine remain on the table. In the 6-month-old position, the pelvis and lumbar spine are slightly elevated from the table while the entire spine still remains straight. The selective elevation of the pelvis and lumbar spine can be actively practiced. The patient attempts to elongate the lower extremities and bring the feet towards the ceiling. This is an exercise to practice pelvic elevation, not posterior pelvic tilting. From sidelying, the patient lifts their body in the frontal plane and supports on the forearm. The forearm is pointed forward in front of the trunk. The patient actively holds the hand in the support extremity in slight extension and radial deviation. The therapist corrects trunk alignment. The trunk, spine, and pelvis are all in a neutral position. This is an exercise in an ipsilateral pattern, and therefore, the position of the pelvic and shoulder axes should be checked. The axes should be parallel, but can be rotated in relation to each other. First, the bottom shoulder blade needs to be centrated. The shoulder blade should not slip into elevation, adduction, an excessive caudal position, or abduction. The therapist centrates the bottom shoulder blade towards the rib cage using both hands, or uses one hand to work with the shoulder blade while the other hand centrates the trunk. The top upper extremity performs active movement. We can either use the weight of the segment, a resistance band, or a different type of weight or loading. The therapist can approximate the bottom thigh toward the pelvis while the patient unweights themselves. The loading of the greater trochanteric area is shifting laterally towards the knee. From this initial position, the patient rotates their trunk around the supported upper extremity. Rotation of the shoulder girdle occurs in relation to the pelvic girdle, while both axes remain parallel throughout the movement. The movement is performed slowly, smoothly, and the bottom shoulder blade, especially, should not lose its position. The top upper extremity is pointed forward as if grasping something. A modification involves the therapist resisting trunk rotation during return movement. Optimal spinal rotation can be trained using oblique sitting position with forearm support. In the starting position, the patient supports on both elbows while the bottom hip and knee are flexed to 90 degrees. The lower extremity is resting freely. The therapist places their forearm ventrally over the lower ribs and the other hand on the apex of the kyphosis. The therapist uses their hand to guide the patient's rotation. The patient is given the following instructions. Push into your elbows while pushing the outside aspect of the bottom knee into the table. Elongate your head and keep the shoulders away from your ears. Weight can be used when exercising in oblique sit with support on the forearm or the hand. Static position can be practiced, as well as small motion lifting the trunk in the direction of the top upper extremity. We can continue with the patient in a similar initial position, this time using their hand for support. The patient is instructed to elongate the top upper extremity so that it follows the extension of the shoulder axes. Maintain the starting position and breathe into your lower portion of your trunk. The therapist exerts light pressure in the direction of the upper extremity and approximates the wrist towards the shoulder joint. Observe whether the patient is able to maintain the position without deviating from neutral alignment. Stabilization can be emphasized in this position by adding a resistance band to the top upper extremity. If the lower knee has a tendency to come off the table, a small foam ball can be used to help the patient feel the movement better. In a similar way, we can activate lateral pelvic stabilizers. The patient continues in their trunk movement and lifts forwards, up, and over the support bottom lower extremity. The top lower extremity can step forward. The patient is on all fours with support on the hands, knees, and shins. The proximal joints are in flexion, slight abduction, and external rotation. The hands are placed under the shoulder joints, and support is evenly distributed throughout the entire hand. The therapist adjusts the alignment of the pelvis, trunk, and head. The position of the upper extremity can be assisted by centrating the scapula and by peripheral support. The therapist's one hand approximates the humerus into the glenoid and incorporates slight external rotation. The therapist's other hand, placed on the proximal forearm, approximates the wrist and observes equal loading throughout the patient's supporting hand. Similarly, the therapist can apply slight pressure on the pelvis in the direction of the supported lower extremity. The patient is instructed as follows. Feel the support, your body position, and the position of your head, trunk, spine, and pelvis. Unload one lower extremity and bring it into slight flexion and then into slight extension. The same instruction can be used for the upper extremity movement as well. Unweight both contralateral extremities without moving the head and the trunk. Do not move the supporting extremities either. Active movement of the extremities can be made more challenging by adding a resistance band. During rotation, the patient should focus on elongating the cervical spine and the head. The patient should avoid lateral trunk deviation. Axial trunk rotation is practiced. The head should not fall into flexion or bend back into extension. If the patient does not master this position, they can modify the position by sitting on their heels or use the 3-month-old position in prone. From the quadruped position, the patient moves their extremities as if they were crawling in a contralateral pattern. In the differentiated quadruped position, support is important. The weight bearing through the hands should be equal, and the elbow should not be hyperextended. The head is in line with the spine without cervical extension or reclination of the head. In this position, the patient will be looking between their hands. Initially, the therapist can assist with the position of the pelvis. The therapist observes the position of the head, the contour of the neck, the shoulder blade position, the connection between the trunk and the pelvis, the paravertebral muscle activity, and the activity of the abdominal wall. The patient should be instructed as follows. Slowly move the unsupported extremity as if taking a step. The therapist can assist by approximation of the pelvis and scapula on the side of the support extremity. The patient should breathe normally. The patient kneels on one knee and the other lower extremity supported through the foot on the mat in front of the patient. The shin bone is perpendicular to the mat, and the axis of the support foot is an extension of the thigh axis of the same lower extremity. Both upper extremities are placed on the table. The pelvis is in a neutral position. The center of mass is not above the support knee, but rather in the middle between the lower extremities. The therapist can check the support by loading the knee and approximating into the foot. The patient should perceive good stability and support when the supporting lower leg is stable. The therapist makes sure the pelvis does not tilt anteriorly. The trunk is in a neutral alignment. Patient instructions. Left upper and right lower extremities are in support. Right upper extremities perform active movement into flexion or abduction. All other body segments should not change their initial alignment. Another exercise is a return arc-like motion of the pelvis towards the heel. The therapist guides the pelvis so that it rotates along the head of the femur. Another option is an exercise in half kneeling without upper extremity support. The center of mass should be between the supporting extremities. The pelvis should not shift laterally. In this position, the patient can practice transitioning between ipsilateral and contralateral patterns. When moving forward, the patient utilizes a contralateral pattern. During the return movement, the patient uses an ipsilateral pattern. Same upper extremity movement can be performed using a resistance band. The band pulls the upper extremity into extension and internal rotation. The patient performs the movement into flexion and external rotation. The range and amount of loading need to correspond to the strength and quality of the stabilizing pattern. Patient is in a half kneeling position. The resistance band is wrapped around the back foot. The patient holds the ends of the band and flexes the upper extremities in front of their bodies to 90 degrees. At the same time, the patient slowly moves back into a sitting position. From the quadruped position, the patient steps forward with their left lower extremity outside the left upper extremity so that the lower leg is perpendicular to the mat and the long axis of the femur is in line with the axis of the second metatarsal. The head is an extension of the spine and the upper extremities are in 90 degrees flexion, external rotation, and abduction. The shoulder blades are in a neutral alignment. The spine is straight and the pelvis can be slightly slanted in the frontal plane. The patient can practice trunk rotation, keeping their eyes on the hand which points to the ceiling. The therapist makes sure that the rotation occurs in the axis of the spine without lateral deviation. This exercise can be made easier by elevating the support surface for the upper extremities. In the initial position, the patient performs shoulder flexion and external rotation. For patients with limited hip mobility who are unable to attain tripod position on the floor, the tripod position can be modified using the table. The support lower extremity is placed below the level of the table, reducing the hip flexion necessary to achieve proper positioning. From the initial position, the patient performs knee extension with the stepping forward lower extremity. The support is on the toes. On this foot, the iliopsoas and calf muscles are stretched. On the contralateral extremity, the hamstrings are stretched and the pelvis is in a horizontal alignment. The spine is straight and the head is in line with the spine. Even in this position, the patient can practice trunk rotation and/or upper extremity flexion. Individual positions and activated movements can be combined. The patient can perform trunk rotation in tripod. They should attempt to maintain the initial position while the upper extremity performs small circles with the weight. The patient stands with their left side next to the table and places the left hip into abduction and external rotation with the knee resting on the table. The degree of flexion and extension may vary between patients. The knee is supported on the medial femoral condyle with the medial aspect of the shin bone resting on the table, as well as the medial aspect of the foot. The right lower extremity on which the patient is standing should be in slight abduction and external rotation. The knee should be above the foot and should not get in front of the toes. The left humeral medial epicondyle should be in support on the table. The trunk is nearly parallel with the table, and the head is in line with the spine. The therapist positions the pelvis into a neutral alignment. The right lower and left upper extremities are in support. The right upper extremity performs active movement with or without resistance. The movement should be executed slowly and smoothly. The therapist checks the alignment of the trunk, head, and extremities. Similarly, the patient attempts to unweight the stepping forward lower extremity, in this case the left, and initiate movement into flexion while maintaining the initial alignment of all the other segments. The patient can perform all previous exercise options with the upper extremity in extension and support on the hand. In this position, slight trunk movement forward and backward can be practiced. The trunk is upright and the upper extremities are not supported on the table. The upper extremities can work against resistance from a band or using weights. The loading needs to be adequate to the strength of the stabilizing strategy and the muscles, ensuring good quality support. In this position, the patient works against the resistance of a band. The active movement of the upper extremity can be performed either through a full range of motion or only a partial portion of that movement. Bear position. Transitional phase during verticalization into standing. Sometimes a child will use this position for forward locomotion. For exercise, we can use 3 or 4 point support or 2 point support on contralateral extremities. The patient is in quadruped. The hands are shoulder width apart and can be placed closer to the knees. Flexion is less than 90 degrees. The head is in line with the spine. The therapist asks the patient to support on the toes. The contact of the foot can either be only the forefoot or the entire sole of the foot. The foot is in line with the shin bone. The patient is instructed to lift their pelvis towards the ceiling. The movement should occur solely at the hip, knee, and shoulder joints. The spine remains straight and elongated. The head is in line with the spine, and the therapist can cue the patient during the movement by placing their hands on the sacrum. The therapist can facilitate correct abdominal activation and intra-abdominal pressure by placing their hands on the dorsolateral aspect of the trunk or on the lower quadrant of the abdomen. In bear position, with support on the hands and the feet, the patient attempts to unweight one extremity without trunk deviation. The therapist palpates the activity of the abdominal wall muscles and the distribution of the intra-abdominal pressure. The following exercise shows lifting of contralateral extremities. The trunk position should not change, and the head should remain in line with the spine. The therapist can facilitate spine straightening by applying slight axial pressure either prior to the exercise or during the active exercise. The pressure should be gradual and occur on a centrated cervical spine. The therapist's contact should be comfortable for the patient. In a bear position, the patient can practice rotation. The patient is instructed to maintain the initial positioning while slowly rotating the trunk towards one upper extremity. Movement should be purely in the transverse plane. In the final position, one upper extremity points down perpendicularly while the other points straight up, also in a perpendicular direction. Another exercise option using the bear position can be having the patient change trunk position as it rotates around the supporting extremities. In a bear position, the patient performs active movement using a resistance band. The trunk is held in space using the other three supporting extremities. The therapist observes the quality of support on the upper and both lower extremities. All extremities are semi-flexed in the middle joints with slight external rotation and abduction in the proximal joints. The patient wraps the resistance band around the lower extremities by placing the middle of the band under the toes, crossing it in front of the shin bones, and again crossing the band behind the knees. The ends of the bands are then pulled forward and wrapped around the hands. The patient kneels in quadruped position and smoothly transitions into the bear position. The patient stands with the feet at least pelvic width apart. The patient performs partial range squats, during which time the knee axis does not get ahead of the toes. The hands can be used for light support on a table. From a posterior view, the lower extremities maintain external rotation and slight abduction, meaning the knees do not come together. From a lateral view, the pelvis does not tilt anteriorly, the spine should remain straight, and the head should stay in line with the spine and does not protract forward. From an anterior view, the trunk should be in an expiratory position and the coordinated activity of the abdominal muscles should be observed. The movements can be performed while holding onto a table or with a therapist's assistance. The patient leans their buttocks back against the therapist's lower extremity. The hip and knee angles should not exceed 90 degrees. A more difficult option is having the patient unweight one upper extremity while in a partial squat. Maintaining this position, the patient performs an isolated upper extremity movement. If a child in bear position decides to get up and walk towards the desired object beside them, they will use a position that we call differentiated squat. In this situation, the child first fully loads both feet. During the movement to the side, one extremity becomes support while the other begins to unweight to step forward. We can observe varied alignments of all the joints. The patient should maintain correct trunk alignment, for example, neutral alignment of the thorax, spine, and pelvis. Lower extremities are more or less loaded with varying degrees of abduction and external rotation. The therapist can facilitate abdominal pressure distribution, especially into the dorsolateral part of the trunk. While guiding the movement, the therapist provides feedback about the spine straightening. This movement occurs in partial range squat. The patient moves from one lower extremity toward the other, which they load more as if they were changing the direction of the movement. The back lower extremity slightly follows the movement of the trunk. The forces acting on the pelvis are differentiated. In this position, isolated trunk movement over lower extremities can be practiced. The extremities do not change their position. The patient practices movement awareness when the trunk rotates over a stable pelvis. The patient stands on one leg with ipsilateral upper extremity support on the wall and the body in a slightly forward lean. The patient moves the acetabulum over the head of the femur while the scapulas glide over the head of the humerus of the supporting extremity. The patient can repeat the movement in one direction or they can switch extremities. Another option is to use a large ball held by the upper extremities as a counterbalance while in a squat. An easier option is to use only the weight of the extremities to counterbalance. During a wall mini squat, with the ball behind the back, the patient needs to maintain a stable trunk and not copy the contour of the ball. The lower extremities are activated in a coordinated fashion. The patient should feel activity not only of the quadriceps, but also the hamstrings. The movement can be modified using various types of loads. The patient sits with flexed hips and knees and the feet resting on the mat. The therapist guides the head and the shoulder blades into a neutral position. The patient is instructed to place their hands on the sides of the knees with the fingers pointing forward. The hand pushes gently into the knees while the patient creates counter pressure through the knees. The therapist assists the patient with a backwards lean. In this position, the deep neck flexors and the trunk stabilizers are simultaneously activated. The patient should focus on the connection between the trunk and the pelvis. There are two different postural situations that correspond to various hand placement. If the patient's pelvis is more anteriorly tilted, the hands are on the outside of the knees. If the patient's pelvis is rather more posteriorly aligned, the hands are placed on the inner portion of the knees. Another option is training isolated lower extremity movement while maintaining the initial position. The patient attempts to maintain straight posture with the trunk in a neutral position. The patient then uses intra-abdominal pressure to control the position of the pelvis and the spine. To increase awareness of the connection between the trunk, the pelvis, and the spine, the therapist can approximate the trunk toward the pelvis. Using slight axial pressure, the therapist guides the trunk towards the pelvis without changing the spinal alignment. Once the patient masters the exercises using assistance, they can perform the exercises without help. The next section includes examples of transitions between individual positions or their entire continuous flow. The therapist can stop the transition at any point or provide resistance in a way similar to the ones described in the individual positions. The entire verticalization process can start from either prone or supine positions. The exercises are performed with the movement vector direction forward or in reverse, meaning against gravity, for example in an upward direction, or gravity assisted in a downward direction. The exercises are performed slowly and with good body awareness. From prone, the patient supports symmetrically on both elbows and transitions into support on one elbow. The patient can look in the direction of the stepping forward extremity. The patient uses their abdominal muscles to prevent the pelvis from tilting anteriorly and breathes normally. In prone, the patient places their hands next to their shoulders. The patient pushes up into hand support with the elbows completely straight but not hyperextended. The trunk is in line with the thighs, and the trunk now moves forwards and backwards while maintaining a straight spine with the head in the same line as the spine. From the same initial position, the patient pushes up into support on the hands and the knees. The trunk remains in the same line with the thighs, and the pelvis is held in a neutral position. The patient steps forward with one lower extremity. The knee is in support, and the palm of the contralateral upper extremity is the second point of support. Contralateral extremities move actively forward. The patient moves forward by creeping on hands and knees. The quality of pelvic uprighting over the supported thigh is especially important. This small movement, or the initiation of pelvic uprighting, can be practiced separately. The initial position is quadruped. The head is in line with the spine. The patient practices stepping forward and returning back to the initial position. The supporting and stepping forward extremities are contralateral to each other. The therapist should note the support on the upper and lower extremities and the positioning of the arm and the shoulder blades. The spine maintains its neutral alignment and the pelvis is held in position without significant lowering in the transverse plane. The pelvis stays neutral in all three planes. In quadruped, with the extremities in a differentiated position, the patient practices movement of the pelvis over the supported femoral heads. The pelvis tilts, and this rotation movement is transferred into spinal movement. Neither the knees nor the hands change their position, and the head remains in line with the spine. In a quadruped position on the mat, the patient moves support from the foot to the toes. The hands are in support at the level of the shoulders. The patient gradually lifts their pelvis up and slightly caudally while the trunk remains straight. The patient moves their trunk forwards and backwards, a rocking motion, while the knees remain above the mat. In quadruped position, with the knees hovering just a few centimeters above the mat, the patient practices movement forward and then backward. The trunk is maintained in line, the extremities are centrated, and the patient maintains respiration with a normal breathing pattern without holding their breath. The head should remain in line with the spine, and the patient will be looking between their hands. From a quadruped position, the patient transitions into tripod and gradually sits on the heel while the upper extremities move away from the mat. The trunk stays upright until the patient sits on the heel. Then, the trunk uprights into half-kneeling position. The patient can use their upper extremities for counterbalance. From the half-kneeling position, the patient returns back to sitting on their heel, followed by trunk movement into horizontal position while the upper extremities move into hand support. In supine, the patient flexes their upper extremities to 90 degrees and positions their lower extremities into triple flexion. The upper extremity, towards which the body will be rotating, abducts to 90 degrees. The patient slowly but smoothly rotates into oblique sit with support on the forearm, followed by supporting on the hand. The movement continues with stepping forward and creeping forward. Support and stepping forward extremities are contralateral to each other. From a 3-month-old supine position, the patient smoothly turns into oblique sit with the hand supporting while paying attention to intra-abdominal pressure. In oblique sit, the lower extremities are placed into hurdle sit, and the transition then continues into the half-kneeling position followed by a differentiated squat. From a 3-month-old supine position, the patient moves through oblique sit with support on the elbow into differentiated squat and returns back by turning around the back hip with the body moving in a vertical direction. The same sequence can be used for reverse movement, from differentiated squat via tripod into oblique sit and ending in the 3-month supine position. The movement can be performed from supine to differentiated squat, or can be smoothly continued towards the other side with the exercise utilizing more space. In a hurdle sit, small movement of the pelvis around the supported femoral head can be practiced. The right lower extremity is placed in a perpendicular fashion in front of the trunk. The palm of the right hand is placed in front of the knee, and the patient practices forward movement initiation with the pelvis becoming elevated above the right lower extremity. The left upper extremity leads the movement forward. From the same position, the patient places the hands on the front of the knees and lifts up into quadruped position and continues into creeping on the hands and knees. The patient returns to the initial position in the same fashion. From hurdle sitting, the patient supports on the ipsilateral hand and via oblique sit transitions into quadruped and creeping. The sequence can be performed also in the reverse direction, creeping to oblique sit to hurdle sit. For this transition, upright sitting with lower extremities in front of the body is the starting position. One extremity is bent with the thigh resting on the mat, while the other is supported on the foot in front of the body. The trunk moves forward and the upper extremities come into support on the mat at the level of the supporting foot. The patient this way transitions into tripod. The same movement can be performed in the opposite direction. From tripod, the patient slowly and smoothly returns to the upright sitting position. From oblique sit with hand support, changing the lower extremity position can be practiced. The lower extremities are flexed in front of the body. The patient alternates support on the right and the left hand, while the position of the lower extremities changes in a smooth and coordinated fashion. The spine should remain upright and the pelvis in a neutral position. The free arm can move forward and upward. From sitting, while the spine is straight and the lower extremities are in front of the body, the patient returns into oblique sit with hand support and follows into tripod position. From tripod, the patient moves up into half kneeling position while the pelvis tilts dorsally over the support lower extremity. The patient continues into a vertical direction and into standing on one foot. The sequence from sitting through the half-kneeling position into differentiated squat can be performed while imagining that the patient holds a plate or holds 2 glasses of water in their hands. To practice movement fluidity, this transition can be practiced using actual tools. From sitting, the movement continues into oblique sit with left hand support and further into bear position. The patient makes sure that the trunk, the head, and extremities maintain correct positioning. During return transition, the patient places the left lower leg, knee, and pelvis into oblique sit, and through free sitting, continues in the same transition towards the right side. From a bear position, the patient alternates the diagonally placed 2-point support on both hands and 1 foot. The free lower extremity is extended and in line with the trunk or moves forward under the supported lower extremity. This is a more difficult coordinated exercise. The patient alternates their trunk position while ensuring centrated position of all the extremities, as well as good intra-abdominal pressure control. The patient kneels with their buttocks resting on the heels and the hands placed in front of the knees. The patient transitions into tall kneeling. They move their hands forward and transition into quadruped and then into bear. The hands step towards the feet, the trunk shifts back, and the patient transitions into squat. From squat, with the knees flexed to approximately 90 degrees, the movement continues into a vertical direction into standing.